We're going to be talking about GLP-1 GIP treatment for lipodystrophy, discussing the latest research and findings and clinical applications. Dr. Oral is a professor of internal medicine in the Division of Metabolism, Endocrinology, and Diabetes at the University of Michigan. She's a leading expert in rare metabolic disorders, particularly lipodystrophy syndrome. Dr. Oral's research has significantly advanced the understanding and treatment of lipodystrophy, including the use of GLP-1 receptor agonists and dual GIP, GLP-1 therapies. Her work has been really instrumental in exploring novel therapeutic options for patients with these conditions. Dr. Cristina Foss-Freitas is a renowned endocrinologist and researcher specializing in metabolic disorders with a focus on lipodystrophy also. She has collaborated extensively with Dr. Oral on studies evaluating the efficacy and safety of GLP-1 receptor agonists in patients with familial partial lipodystrophy. Her contributions have been pivotal in advancing clinical knowledge and treatment approaches for lipodystrophy syndrome. So I will let you take it away with your slides.
Okay, thank you. So I think what we planned is I'm going to start with an introduction of what we have about what we have done with GLP-1 and GIP. And then Dr. Al will answer a lot of questions that you already sent and also whatever questions is come out. So I'm going to share my...
We can answer them together too, so,
Okay. I will share my screen. Let me know if you can see this. Does everybody see my screen? And
yes, perfect.
Okay. So let's start. Okay. So we're going to talk about GLP-1 and GIP treatment in patients with lipodystrophy, and especially in patients with partial lipodystrophy. And to start, I'm going to present a case of one of our patients that started this whole idea of doing this kind of approach in our patients. So this is a 38-year-old female. She has partial lipodystrophy and FPLD2. And she had a story, as a lot of you know, of episodes of pancreatitis, liver disease, and diabetes. But she also had an infertility problem. And in that moment was, and that was the start of everything. So she wanted to get a treatment for her infertility. And the first approach was to do a very low calorie diet. This diet was basically 800 kilocalories per day. So that was very a small amount of calories. She took this on a shake that was pretty balanced in terms of carbohydrate, protein, and fat in the diet. And the goal of this treatment was to reduce her body weight in 15%. This is a program that is ran in the University of Michigan for a long time. It's the weight management program, and it's very well established, and it starts with 1 week on this diet. And so it starts with this diet that is basically a shake. And just with 1 week on this diet, she was able to discontinue her glucose and lipid therapies. So that was really striking. And what I'm going to show you is the evaluations that we did at baseline and post-treatment. So she was 12 weeks on this very low calorie diet. And then after this 12 weeks, she was with 4 weeks of a transition low calorie diet where she was replacing some non-starchy vegetables on her diet, but was mainly very low, it's still a low calorie diet. So this is, can you see everything or do you see this? You see everything. Okay. Stop with my thinking. Okay. So what we see here is that after 16 weeks on diet, she showed a reduction in her body weight of 12.3 kilos, and a very important reduction in her A1C in 1.4%. So here in this table, we have the baseline values for several parameters like body weight, BMI, A1C, and a lot of labs that was done on this patient. And then the the following column here is the post-treatment evaluation for all the same parameters. And on the last column here, you see the percent change that she got. So it's very important, the percent change on body weight, in A1C, in triglycerides. She had 37% reduction in triglycerides, and also in liver function and on basal insulin levels. So this was also associated with a reduction in insulin resistance, and we measure insulin resistance as a global insulin resistance measured by the HOMA-IR, and also by the resistance in the adipose tissue, that is the adipo-IR. And both of them showed a very important reduction in these insulin resistance. Looking at her body fat, we saw that there was a decrease in the total body fat. So here is the fat shadow. For those that are not used to see this image, everything that is in yellow here is the fat, in the body. And I would tell you, pay attention to the counter of the yellow here, because this is the subcutaneous fat, and this is the one that we are most interested in looking at. And you see that there is a reduction from baseline to week 16, especially in the areas where the fat is mostly accumulated on the upper part of the body. Whoever has FPLD or knows someone who has FPLD know that this is the region where it's most difficult to mobilize the fat. But here are the graphs showing the percent of the total fat. So we calculate this, we give numbers to this image, and this is the percent fat, the total fat, and there was a reduction. And we also looked at the liver fat, because she, as I said, she had a liver disease that is associated with the FPLD, and she also had a reduction in the liver fat. So the treatment was good. It worked for her. Her infertility issue was resolved at this moment, and she was able to do what she wanted from the fertility point of view. But we said, okay, we are seeing that reducing the food intake is good, but doing a diet with very low calorie is very complicated, and not everybody is willing to do this. And sometimes you need to do this in a long term. When you have a purpose of looking only for infertility and doing like a procedure or anything, that is a pretty good option. But if it's for a long term, it's complicated. So that's when we said, let's see what happens with people that are being treated with the GLP-1 agonist, and also with the dual incretin therapy. So Dr. Oral has those patients. She is treating them with those approaches. And then we looked at the data in a retrospective fashion. We got the charts of these patients. We look at the electronic medical records, and we got some information like demographics, the weight, the BMI, the triglycerides level, the glucose, the A1C of these individuals, the diabetes, and the triglyceride level, or the medication that they were using for diabetes and triglyceride, and other medical events. We also were very careful on looking if there was any pancreatitis, gallstones, or any cardiovascular events. For this this study, we looked at 17 patients with familial partial lipodystrophy. The age was in average 68, and most of them were females. And we compared these people with individuals with type 2 diabetes, also 17 type 2 diabetes, and we paired for age and the percentage of sex difference. And we then evaluated everybody that was treated for at least 6 months on the GLP-1 agonists. And what we found was that we had in total 14 patients with FPLD in this study, because 3 of them did not have the 6-month follow-up. But from those, 3 were male and 11 females. And what we looked and what we saw was a reduction in A1C, in triglycerides, a significant reduction in fasting glucose, in the weight and BMI of these individuals when we compared, when we looked at the baseline and the follow-up. When we compare them to people with type 2 diabetes, I'm not showing the data here, but we did also see that there was a better response on triglycerides in the patients with FPLD treated with GLP-1 analogs and compared to the people with type 2 diabetes. So this is a retrospective study. We need to keep that in mind, but this is something that we saw. 2 patients with FPLD developed acute pancreatitis, but this was just during after they stopped the medication, and during the follow-up, they developed these episodes of pancreatitis. So we are not sure if this was drug-related. Probably it's just related to the baseline disease that they have. And of course, both cases had prior history of acute pancreatitis. Most importantly, what happened to their medications, right? So most of them either reduced the insulin intake, they had to lower their insulin dose, or they stopped the use of insulin. So that looks very promising. And then we also looked at the effect in kind of the same fashion, but this is more recent because it was looking at the use of Tirzepatide, that is the association of GLP-1 and GIP. And we looked at this for in 17 patients again. Now we have not only FPLD, but we have atypical partial lipodystrophy and acquired generalized lipodystrophy. The age of these people are between 30 and 74 years old. And from the 14 patients with FPLD, all of them had diabetes. And with the dual analog, we see a very important or a significant change in BMI, A1C, triglycerides, and they all, mostly all of them either reduced or even stopped the use of insulin during the treatment. And so the adverse events that we saw here were limited to the gastrointestinal symptoms. That is something that is expected in this treatment because this is a side effect of the medication, and it is known that can happen. We didn't have any serious adverse event. So what are the future directions, what we hope to do in the future? So we have a NIH trial that is hopefully gonna be funded soon, and we are preparing to launch this study very soon. And the idea is to, in this study, do the dual incretin therapy. So we will use the Tirzepatide on the treatment of these patients in a prospective way, because then we can really collect all the data in a very comprehensive way. Whoever did any study with us here know that we really try to collect all the information that is possible, because this is very important. And what we want to see is the impact on the weight loss, the impact of the weight loss on any residual adipose tissue health, liver health, and physical appearance in these patients, and probably address what needs to be answered in this field. So from the questions that we had received previously, I put this slide just to try to start the conversation, but I think that maybe it's better to ask if there is any question from the audience. I think there is something in the chat, right?
Yeah. Just before the questions, can you maybe just give a small explanation about what the mechanism of action of GLP and GIP and what GLP and GIP means?
Mm-hmm. Yeah, sure. So GLP and GIP, I don't have slides for this, but I can explain. They are intestinal hormones. So they were found when people were trying to study the effect of the glucose tolerance test. We know that when you take glucose by through your mouth and goes through your intestines, it has an effect on releasing insulin through the pancreas. And then they found that this effect was due to the stimulation of some parts of the intestine that release those hormones called GLP-1 and GIP. And one of the effects of those hormones are to increase the insulin secretion by the pancreas. That's why they started everything, and that's why it was studied, and they started doing this for people with type 2 diabetes. But then they also found that the GLP-1 not only has that effect on the pancreas, but it has effects on other parts of the body. So it slows the gastral emptiness, so you feel full for a longer time when you take those medications. And then it also acts on the central neural system in the brain, and it controls the satiety. So it does regulate satiety and hunger in a very well-known fashion. And this is the effect of the medication. The advantage of having the GIP together with the GLP-1 is because when you have the GIP, it kinds of mitigates the effect of in the brain and in the especially in the brain, and the sensation of nausea that you get when you take the GLP-1. It's this is known. Everybody who takes GLP-1 usually have some nausea. And this is the effect that is expected with the drug.
So, I mean, I think if I could just jump in and say a few words here on mechanism as well. So, the biggest problem in partial lipodystrophy is that there is a mismatch between the fat tissue storage capacity and the food intake, right? Like, or the calories that are coming in. Um, the adipose tissue's storage capacity is much smaller compared to individuals with symmetric fat distribution, and that leads to ectopic steatosis, or meaning that fat, the food we eat, the extra calories, get turned into lipid and then eventually go to places where it doesn't belong, not because it can't find a safe place in the fat tissue. Instead, it goes to the liver, it goes to the pancreas, it goes to the around the heart, and all of that creates insulin resistance. This contributes to more fat production from the liver in a dysregulated manner, and basically creates what I would say metabolic havoc, right? So um, if so the idea of taking a strategy to reduce food intake is, if we cannot expand the adipose tissue's storage capacity, then can we make an impact by reducing food intake? So that was like the idea of trying the very low calorie diet. And, we've used it for our patient who was seeking a fertility treatment. But as Sharon heard in Paris, like the Cambridge group was also exploring very low calorie diet for their patients with partial lipodystrophy. And then when our results were really remarkable in our hands, we then turned to looking at what happens with GLP-1. By the time we decided to do that, there were some patients who had found themselves on GLP-1 that were in our registry studies. So that's sort of like how this study came about. Now, as Maria said, GLP-1 and then the GIP are two hormones made by the gut. They're like the yang and yin of the gut. And they work in a coordinated fashion in some situations, but opposing ways in other situations, depending on the context and what kind of food is coming in. And their job is to prepare the rest of the body to incoming nutrients, okay, and how to handle them. Among one of the effects is slowing food absorption. Another effect is to tell the brain that, yeah, there's been a lot of food that came into the gut right now, so I should not want to eat anymore. So that's another signal. And it turns out that that part of the signal really crosstalks with the fat signal leptin, right? So apparently they use some of the same neurons to control our desire to eat. So leptin's effect on reducing food intake and GLP-1's signal to reduce food intake, there seems to be a lot of overlap in the neuronal populations in the hypothalamus. Anyway, so our data in both with GLP-1s and with tirzepatide suggests that the use of these drugs is beneficial. A big part of the effect is reduction in food intake, but there may be other beneficial effects that still need to be studied. So, for example, are the drugs making the residual fat less inflamed, right? So if that's the case, that will be also helpful for overall inflammation, pain, etc. And I do believe that there's a big chance that we will see that, okay? We don't have enough data to prove that kind of a hypothesis at the moment, but in our prospective trial, that's one of the important questions that we hope to answer. We will be looking at both systematic inflammation, adipose inflammation, and also to some extent, liver inflammation as well. I will be able to tell you, let's say 2.5, 3 years from now, like all the effects, hopefully, that these drugs have in the body. But at the moment, I mean, the idea that there's, from multiple lines of evidence, we could definitely say that because we cannot expand the adipose tissue storage capacity, a strategy that lowers food intake, regardless of what that might be, seems beneficial for patients with familial partial lipodystrophy. Reduction of food intake on a long-term basis isn't feasible, right? You know, it's very hard. And especially when you have hyperphagia to begin with, it would be very difficult to maintain that over time. So the drugs definitely help with making that effect long lasting. And I think there was a question about food noise. Many of the patients who've taken this drug do mention that the food noise is positively impacted, right? And that's not only specific for FPLD, it's for also for people who have insulin resistance and type 2 diabetes and obesity. You know, there is probably some similarities in how patients are responding. That's definitely one of the effects. So the question that was asked, why does the food noise seem to return a day or two before the next injection? I mean, I think those are like how the drugs are designed. You know, they're probably, you know, they start to clear from the system a little bit, and then you know, that it's not really lasting the full 7 days, but more like 5, 6 days, which is not a terrible thing because, you know, I think this is what our patients are telling us, that, you know, there's at least one day that or two that, you know, people can still remember, like enjoying food or something along those lines too. So at the beginning, you know, when we start these drugs, patients experience almost no appetite for a while, and then the longer you stay on them, that gets better. Where we want to be is be at the place where people are actually not nauseated, right? They are not extremely fatigued. They're not throwing up or having GI side effects. They're able to continue their normal day, but not thinking about food all the time. And then they still get hungry, you know, in between meals, and will then eat what their body needs for nourishment. So when you first start the drug, you know, it's new to the body. The signal is really augmented with these therapies. So it takes a little bit of time to get used to. That's why we start at a low dose and gradually increase the dose. So there was another question whether we need to go up all the way to the maximum dose. I would say that this is where the art of medicine would come in. You know, in the clinical setting, we could certainly individualize how fast we go up and to what dose we will reach. Okay. And that's, so we take the response from you, from our patients, and then we go up. If we feel like people are tolerating and then they still need improved metabolic parameters. If I'm reaching all the metabolic goals and people are doing well, I don't think that it's a must to go up to 15 milligrams. Of course, when you design a study, the studies have to have set protocols and you have to follow protocol. So our protocol, for the prospective study will aim to get people to 15 milligrams, but we do have some leeway to make adjustments based on side effects and parameters. So again, medicine is an art, right? Not just pure science. So you have to individualize according to patient's response. So can Mounjaro make blood insulin levels go up, although A1C is down? It could, because as Maria said, one of its major functions, or one of GLP-1's major functions, is to get your pancreas make more insulin to deal with the glucose load that's about to hit. But because the other effects help to improve insulin resistance so much that while your meal response may end up being like a healthy level of insulin response, your fasting insulinemia tends to come down. Okay. Overall. So that's what we see. But of course, again, our study will give us far more robust data to tell you in the most accurate way. Another question that came. Okay, go ahead.
And Dr. Al, what we're seeing from our studies is that sometimes the increase in the insulin levels are associated with a better insulin sensitivity.
Yes.
So it's a good thing
It's
that
a
it's
good
happening.
thing. And
It's not
that's why
bad.
the sugars will come down also.
Yeah.
Right? So why can't I take Ozempic if I had pancreatitis in the past? It's not a definitive contraindication. I would say, again, the art of medicine plays a role here. I tend to really individualize. If someone has had a lot of pancreatitis episodes and I know their pancreas has had structural damage from their recurrent pancreatitis episodes, then I'm more careful. And in the clinic, when I am thinking about this, I always talk about the risk of pancreatitis, especially if people have had previous episodes of pancreatitis. And I want my patient to sort of be on board. In clinic, a treatment decision is shared decision making. So if my patient is willing to take on that risk and is interested in trying, I would be willing to do that for the most part.
With the pancreatitis, is it better to take Ozempic or Tirzepatide, Mounjaro?
So it seems like the pancreatitis risk is probably a little bit. I mean, there have been more episodes noted with GLP-1s in the literature compared to tirzepatide. Part of it is probably the GLP-1s have been around much, much longer, and the earlier ones, were sort of like really rapid acting and they sort of like did whatever they needed to do really quickly, and then their levels sharply came down. And the up and down might also have perhaps like may play a role in bringing some factors up and down quickly. May sometimes trigger local inflammation in some organs. I don't know that, but some of the pancreatitis risk that's in the label in the United States has carried over from the earliest, from Byetta, from liraglutide, so semaglutide and tirzepatide, the risk of pancreatitis or the number of observed events of pancreatitis are much smaller in the literature. Taking everybody who's been exposed. Can someone with recurring events of pancreatitis take Mounjaro? Or Zepbound, they're the same drug. So again, this is a very individual decision. And when I'm making a decision for an individual patient, I will take a lot of things into consideration. Did they have structural damage? Do they have additional risk factors for pancreatitis? Like, are they on estrogen? Are they drinking alcohol? Um, how are their triglyceride level controlled right now? So I will take all of those things into consideration, and may still offer a patient with history of pancreatitis, and I do, starting Monjaro. And if anything, what we're seeing for the most part is perhaps a prevention of pancreatitis episodes. But I'm hesitant to make generalizations because there may be some circumstances that will really refrain me from making a recommendation for a patient. And most of it has to do with the current state of their pancreas. Okay, so brings these questions to an end. So I'm going to go through the chat now and see what's
One of the questions in the chat is that you were talking about your clinical studies on patients with type 2 familial partial lipodystrophy. So is this effect can be seen in type 1 as well?
Yes. So our study will enroll both type 1 and type 2, all types really. And we've done our retrospective evaluation on all types as well. Our diabetes care paper does have FPLD type 1 patients, and we do see as much improvement, if not more, in them as well. So this seems to be a universally applicable strategy for FPLD. So our preliminary data is fairly good to say that. And then another question that comes to mind is, would these drugs work together with leptin? Will they work synergistically, help each other, or will they reduce each other's effects? So our current data does suggest that they work synergistically. We've had the opportunity to observe a few patients clinically taking both drugs, both on the generalized lipodystrophy side and on the partial lipodystrophy side. This is very early data, and this is observational, but we will be talking about it at the Endo Society meeting, and our preview, just if I could give you a one-liner that it's a positive effect, but I can't give you like a PowerPoint slide of the data because it's under embargo. Actually, we don't even know if we submitted as a late breaking abstract. So hopefully the results of those will come out next week or so. Hopefully it got accepted. And then hopefully we can disclose the results. Okay, so let me start with to the beginning. Are these drugs as effective for those with FPLD type 1? So we answered that, right? So the trial and whatever data that we have collected did include both FPLD type 1 and 2. Are you doing or will be doing clinical trials with retatrutide with FPLD patients? We're not doing any at the moment. We will consider doing that for sure. Are these drugs decreasing body fat solely due to decrease in food noise, allowing the patient to lower calorie intake? I don't think that's the sole effect, but again, there are quite a few different possibilities with adipose tissue, fat tissue inflammation being really high on my list. And hopefully I'll be able to answer those questions for you, when we complete our trial. I don't think that the fat cells decrease with these drugs. I mean, one of the questions was, do these drugs somehow cause the fat cells to decrease? I don't think that fat cells decrease in number. I think the engorgement in the fat cells, like the residual fat depots. So if imagine, in FPLD, more than half of the fat depots that you would see in a person with symmetric body fat depot gone, right? And so your storage space is so much smaller. So it's trying its best to expand, right? And whatever depot there is, it's experiencing engorgement. And the more engorgement there is, there's more inflammation in there. So I think, you know, the fat cells are forced to offload some of the extra lipids that they've been sort of trying to take up, and that helps the inflammation. That's again a prediction, a learned guess, educated guess, but I will hopefully have data to prove all of that. Can you explain the differences between GLP-1s and GIP GLP-1 dual analog? I think Maria did a good job in explaining that, right? You know, GLP, so basically the gut makes two kinds of hormones, yin and yang, as I mentioned, and the GLP-1 agents augment the signal for GLP-1 only, and then the dual signals augment both GLP-1 and GIP. And clinically, what we do know is that if you augment both signals, the clinical impact on reduction in food intake and insulin sensitivity is, and the weight loss is bigger, you know, when you do both signals versus one, you know, and that's been proven not only in FPLD, but also in type 2 diabetes and also in common obesity as well. Next question is from Wendy. How do we apply for a clinical trial? That's very easy. As soon as we launch, we will let all patient organizations know. Lou will hopefully help us put the buzzword there, and then people can contact us, and then we will do our best to bring.
But I can put my email here,
Yeah.
and whoever wants, just send me a
Yeah.
note, and we can keep this registered, and we will contact you as soon
Yeah.
as we can.
Yes, so thank you for that, Maria. Thank you for offering to put your email. Next is from Nicholas Kader Jensen. If a patient had significant adverse gastrointestinal effects on Ozempic, would going on Tirzepatide cause the same effects? NIH recommended moving from one to the other, but the primary care physician is concerned. I've seen multiple instances where people actually respond better to Tirzepatide, you know, in terms of the nausea and vomiting side effects. But that doesn't mean that it won't be observed. Again, if you're willing to take the shot, literally and figuratively, I think it may be worth trying it based on my experience. When you mention lower calorie intake, how are you talking? How low are you talking about? So
800, I think
yeah,
that
our
is it.
VLCD was down to 600 calories for the first 6 weeks, and then 800 calories for up to 16 weeks, right? So it was very low caloric intake on the very low calorie diet intervention. That's what our weight management program does. You know, it's their algorithm with the OptiFast diet program. So it's a very low calorie diet, which means that you would have to take some multivitamins and calcium and vitamin D.
Yeah.
Because
And you
otherwise,
can usually not take it for a long time. It's limited, right?
Right,
You cannot do this kind of diet for a long time.
Yes.
And it's correct. If you reduce from 2,000 or 2,500 to 1,200, that is a low calorie. Yeah. Every time you reduce your calorie intake by at least 20%, this is considered a calorie reduction. But for this study particularly, we wanted to use this already established protocol that uses this 800 calorie daily. That is very low, so it needs to be monitored and it needs to be done in a medical setting.
any information on effects of patients with acquired partial lipodystrophy. We have one patient who's tried it. Most patients with acquired partial lipodystrophy don't develop as many as severe metabolic side effects, but there are handfuls of individuals who do. And if we have patients who experience metabolic abnormalities, diabetes, hypertriglyceridemia, it's been used and it's been working just as well in them as well, for improving their overall body weight, triglycerides, and liver. So we've done it in one of our patients in a prospective manner ourselves, and I've seen another patient whose primary endocrinologist had done it. So so far experience is very little. So let's see, are patients already taking Mounjaro eligible for the trial? They will be, but we would have to have some period of washout, right? So so if people are willing to do a washout and then help us collect the evidence base, and that's more of an altruistic thing at that point, right? You yourself, may not benefit directly when you say, okay, this is a therapy that works for me, but I'm going to do this for my community. So I want to really participate in the trial and contribute to collection of data. So, I mean, we would be so indebted if people would do that, but, we cannot force people to do that, of course. But we would so much welcome it, but we don't want you hurt in the meantime. So if you would like to discuss that with me, I can certainly work with you and consider it after the trial is launched. So and then maybe this is like a good time for me to say just one thing. I wear two different hats, right? Like I'm a physician foremost, and when you come and see me in clinic, I have to do what's best for you and give you my best advice. But my other hat is the researcher hat. And then when you come and apply for a trial, then, being the researcher, then I have to do also what's best for the study and, for the most objective data collection. Because at the end of the day, what we learn from these clinical trials provide the evidence base that will lead to drug approvals or insurance companies providing drugs for certain indications. So, and contributing that knowledge is so important for the communities and for the society at large. And this trial will be funded by NIH, which means the taxpayers are paying for the research to be completed. So we do owe it to everyone, all the stakeholders, to collect the best data for the trial. So there's a little bit of difference, when I wear the two different hats. I try to balance it really, really well, and at the end, we really want to do right by you, and all the research we do, it's all for the community and for the patients. You all inspire us to do our work, both clinically and also in the research world. And our goals is to really I hope that I don't get to retire until I see a cure or two, of one or two syndromes cured. I hope, God will give me the longevity, or like the research career to see all of that happen. And we won't stop, unless something natural comes and intervenes. But I really hope, we work and keep giving you good news, good results, and lots of therapeutic options. Okay, and it's our job to also use all the tools in the toolbox, right? Like and create the algorithms that will help you in the clinical world. Okay, so next is, have you seen diarrhea as a side effect of using tirzepatide in your lipodystrophy patients? If so, is it significant enough to cause discontinuation? Do we have any pre-treatment indicators to point towards robust response with GLP-1 and or GIP agonists? So the second part of the question, I think I'll be able to tell you more once I complete the prospective trial. In a retrospective manner, it's hard to say, like with retrospective data, hard to answer questions such as that. But for the most part, so far, I should tell you that most patients did respond. Okay, so it seems like that's a given. The tolerability does vary, and it would be great to try to figure out what factors contributes to poor tolerance of these drugs in general, like even in our type 2 diabetes populations as well. And that's just something that I'm working with our GI colleagues. Sometimes, if people have a lot of GERD, like gastroesophageal reflux disease to begin with, or a lot of gas and stomach emptying problems, I try to get them seen by GI before I initiate therapy with these agents. I also have not shied away from sending people for endoscopies and MRI scans for looking at their pancreas structures. So we've collected some data. So hopefully we'll be able to answer those questions better. In terms of diarrhea with tirzepatide, I don't see that as a major side effect. Okay, so it's more with metformin than with this. If anything, there's probably more constipation that I hear back than diarrhea. But again, I mean, if somebody does have like a very backed up colon, putting a drug on board that's going to change GI motility could eventually lead to leaking stools, and that can present clinically as diarrhea, right? So and poorly controlled diabetes and autonomic neuropathy can contribute to GI motility issues. Lamin mutations, they themselves, after all, the bowels and the stomach and the esophagus, stomach and bowels have smooth muscle, right? Exactly. And we know lamin is important for all muscle, for heart and the striated skeletal muscles. But what it does in smooth muscles isn't very well understood. All I could tell you is that in our registry, one of the newer things that we've uncovered is a lot of GI dysmotility, right, Maria? GERD and
Yes, a lot.
this sort of alternating gut movement abnormalities, constipation, diarrhea, irritable bowel like symptoms. We do see that more often than what I would expect in the general population in our registry. So I could tell you. Okay, so are you?
Do you have any experience with tirzepatide while pregnant?
No, and we typically, if somebody's pregnant, because there's no data, we would not keep people on it, unless data emerge. There's no data that says that it's going to be detrimental, but because, typically, you really need a lot of data to accumulate to suggest safety, or some controlled trials, people finally decide, okay, let's do a study in pregnancy, and then we would do it. I would be worried about using tirzepatide in pregnancy, mostly because of the caloric reduction, and the nausea side effects. So,
But also going off tirzepatide for pregnancy can be somewhat dangerous.
so let's have you say that. Okay. Okay.
Yes,
Yeah.
I agree
So,
with you.
or like going off of it. I mean, the one thing that I will also say with these drugs, I don't want people to discontinue them abruptly, especially if they've had pancreatitis before. We've had at least one instance where, because of the shortage, somebody was doing really well on tirzepatide, had to come off like without warning, and then that kicked pancreatitis. So if there was a way that I could actually slowly taper it back down, I would try to do that if somebody needed to come off. So are you eligible for if you're already on the leptin trial? So the FDA doesn't allow people to do two trials together, two drug trials. So you would, if you're on the leptin trial, the hope is that you would finish that and then consider participating in the tirzepatide trial. Now, if you're on the leptin trial and you finish the randomized portion and you're on the open label extension phase, then there are rescue criteria, right? And based on the rescue, I think what drugs that people will put people on is not specified. So it's up to the investigators at the different sites to choose what's in the best interest of the individuals who need incremental therapy. Is there any magical way to get insurance to cover Monjaro if you're not diabetic but have FPLD too? So if there's no magic way, but if your BMI is high enough to qualify for Zepbound, and the coverage for Zepbound has really become restricted for weight loss in this last, let's say, 8 to 12 months. And insurances are always, they have their own, I will say, idiosyncratic way of looking at things, and their first instinct is to refuse anyways. The sleep apnea might help us to get approval for Zepbound. And then soon there will be an indication for metabolic liver disease and Ozempic or semaglutide, Wegovy. So, so I try to get those studies completed for patients if I want to augment their therapies. Will this clinical trial, in my clinical trial, you'll be able to come in even if without diabetes. Will this clinical trial help us with FPLD qualify for the medications with insurance companies? That's our greatest hope. That's why we want to do this study. I think if we can show that people with FPLD specifically benefit, and here's why, this is, A, B, C, D, E, improve, then, that's what we hope to accomplish. Important points to highlight regarding GI evaluation patients on such incretin-based therapies. Important point. Okay. Thanks for all the answers you can provide right now. Okay. Looking for more information in this space. Yeah. So, yes. So we will definitely follow up with you on those GI evaluations. How many people are we going to take on the Monjaro trial? We are going to enroll 30. And half of the patients will start the drug right away. Half of them will follow them parallel for 6 months and then start the drug 6 months later. But everybody will get it. Certain pharmacies won't even stock the medication because insurance is not reimbursing them enough. That is true. That there was a big shortage nationwide. And then not every pharmacy has a big stock of them. Bigger chains have more of it. So CVS, Caremark, specialty pharmacies, Walgreens, specialty pharmacies, and then Costco seems to stock quite a bit in my experience. But and there's no more shortage, but not every pharmacy can get it for every patient at the right time. So I tell patients to find the bigger pharmacies, not the small like family-owned pharmacy businesses. So I mean, if they're willing to work and get it for the patients, I mean, nothing against the smaller pharmacies. Please don't get me wrong. Just you know, like the physical ability to get it.
Okay, well, it's been an hour. Thank you so much for you guys for the amazing talk and answering all of our questions. If someone has other questions, you can send them to us and we will transfer them and make sure you will get an answer.